Hello and warm welcome to today's talk. I'll be covering about bronchiectasis, another important exam topic in the next 15-20 minutes. Okay. So what is bronchiectasis? Bronchiectasis, bronchi means the bronchial segment and the ectasis means dilatation. So in bronchiectasis, there is abnormal permanent dilatation of the bronchi and the bronchioles. Generally, it's because of inflammation secondary to repeated bacterial infection. Okay, normally you have the mucociliary apparatus which pushes the whatever we inhale, it pushes the foreign body or the organisms, brushes it up to the esophagus and we swallow it. That's how it is. It's a defense mechanism which works against infection. That will be affected in bronchiectasis. What are the infection commonly causing associate bronchiectasis? Haemophilus influenza, strep pneumonia, Staph aureus, and Pseudomonas aeruginosa. These are the infection commonly responsible for bronchiectasis. Okay, so coming to causes, it can be congenital because of cystic fibrosis. It can be because of Cartagener's and Young syndrome. Cartagener's is you have sinusitis, situs inversus, and bronchiectasis. Young syndrome is a condition in which we have mucociliary dyskinesia. Okay. Obviously, if the mucociliary apparatus is damaged, the defense mechanism will not work. Infection, measles, pertussis, tuberculosis, HIV, bronchiolitis. All these are common causes of infective causes of bronchiectasis. Then it can be secondary to obstruction because of a tumor, which can be intraluminal or some pressure from the extraluminal tumors can cause obstruction, which can lead to bronchiectasis. Any foreign body aspiration can cause obstruction and bronchiectasis. Hypogammaglobulinemia. Again, the defense mechanism will be affected if the gamma globulins are reduced. Again, you can have bronchiectasis because of that. One important cause is allergic bronchopulmonary aspergillosis. That's another cause for bronchiectasis. Then you have rheumatoid arthritis. So all these are causes of bronchiectasis. Now, how do they present clinically in bronchiectasis? Normally, clinical features will be patient will have cough with copious foul-smelling sputum. Cough with copious foul-smelling sputum. They can have intermittent hemoptysis. Remember, this hemoptysis can sometimes be life-threatening. Okay, and if the patient has superadded infection, patient can present with fever. So cough with copious sputum, intermittent hemoptysis, and fever. On examination, the patient will have clubbing, and once you auscultate, you will have coarse, leathery crepitations. So the 3 C's are cardinal signs of bronchiectasis: cough with copious sputum, clubbing, coarse, leathery crepitation. Sometime on examination you can have rhonchi, especially if the patient has associated asthma or COPD. Okay, these are the clinical features. Okay, what are the complications of bronchiectasis? One, hemoptysis, I told you, it can be life-threatening. So in such condition, you will have to do a bronchoscopy to identify the bleeding vessel and arrest the bleeding. So hemoptysis is one important complication. The patient can have superadded infection or pneumonia. Patient can go in for pleural effusion. I told you, pleural effusion, it's called parapneumonic effusion. And you can have pneumothorax because of one complication. Finally, amyloidosis is a complication. Also remember, long-standing bronchiectasis can result in respiratory failure. Okay, these are all the complications of bronchiectasis. What investigation can we do? Now, apart from the blood routine, TC, DC, ESR, hemoglobin, all those things, a chest X-ray. What will you see in the chest X-ray? Most of the time it can be normal, but at times you can have cystic opacities. Tram lines can be seen. Tram lines are nothing but the bronchial wall edema will cause tram line appearance in the CT as well as chest X-ray. Then you can have cluster of grape appearance in the chest X-ray and also in the CT scan. A high resolution CT is the gold standard investigation for bronchiectasis. It virtually diagnoses bronchiectasis. You can do a spirometry, assess the lung capacity. Bronchoscopy should be done especially if you suspect any obstruction. It has to be done. And also I told you another indication of bronchoscopy is hemoptysis. Okay, so that you can see which vessel is bleeding and arrest the bleed. Sputum examination can be done if you are suspecting superadded infection. If the cause is not known, you need to do certain special tests. Suppose if you are suspecting hypogammaglobulinemia, you'll have to do protein electrophoresis. If you are suspecting allergic bronchopulmonary aspergillosis, you have to do skin test, allergy test to make a diagnosis of allergic bronchopulmonary aspergillosis. Rheumatoid arthritis, if the clinical features are suggestive of rheumatoid arthritis, do RA factor and other investigation to confirm the cause for bronchiectasis. Now, how to treat bronchiectasis? Postural drainage, okay, chest physiotherapy. These are the two main pillars in treating bronchiectasis. Bronchodilators can be used, especially if the patient has superadded, like salbutamol nebulization, especially if the patient has associated asthma or COPD. Steroid can be given, especially in patients who are having allergic bronchopulmonary aspergillosis, and surgery if you feel that is it's a localized, if the CT reveals that it is a localized bronchiectasis. CT is important because it will give you an idea about the extent and involvement of the lung. Okay, so the apart from this, the anatomical types you will have to know in bronchiectasis. They are fusiform, saccular, and cylindrical. Okay, so this pretty much summarizes what all you have to know about bronchiectasis from an exam perspective. Okay, thank you.